Thanks everyone for joining us, and welcome to Cases from the Community as investigators discuss applications of available research for the management of patients with diffuse large B-cell lymphoma. I'm joined by an august faculty today, Dr. Matthew Lunning, who joins us from the University of Nebraska, and Dr. Laurie Sehn from the BC Cancer in British Columbia. And I'm Dr. Christopher Flowers, professor and chair of the Division of Cancer Medicine here at UT MD Anderson in Houston. So as you'll see on the slides, the accreditation information involve research to practice and the Medical Learning Institute that we're providing ACCME credit as well as ACPE and ANC credit for this, and provides continuing medical education. The disclosures and conflict of interest for this are based on Medical Learning Institute's commitment to providing high quality CME to healthcare professionals, and you'll have disclosures for all the presenters today in your conference materials. You saw them rolling through the slides that we presented earlier. And the planning committee and the content reviewers received help from Medical Learning Institute as the accredited provider and research to practice as their educational partner. And these briefly are the disclosures for Dr. Lunning, for Dr. Sehn, and for myself, which are all included in your conference materials and packet. I will mention that we will also talk about unlabeled uses of approved products as well as investigational uses of agents that have not yet been approved by the FDA, and that each of you as participants have responsibility to use this newly acquired information appropriately. So let's jump in without any further ado and talk about our cases from the community as our investigator group discusses the ways that new data can be applied for patients with diffuse large B-cell lymphoma. So we have a set of cases that come from community practitioners. These are real live cases from practitioners across the country, and you see the list of contributing practitioners who were part of this discussion, and you'll hear from each of them in video snippets that will come out in the coming sessions. So first, we'll hear about upfront therapy from our community practitioners and the cases that they have, and have an opportunity for our participants to be able to comment. And I'll give a brief description of upfront therapy and changes in therapy for diffuse large B-cell lymphoma. Next, Dr. Lunning will talk about selection and sequencing of therapy with cases applied there. And Dr. Sehn will talk about bispecific antibodies in the management of diffuse large B-cell lymphoma. So let's jump into module number 1.
Good afternoon, everyone. I'm Neil Love from Research to Practice, and welcome to our real-world case library, today featuring a number of community-based general medical oncologists with patients with diffuse large B-cell lymphoma, including the following cases with advanced stage disease.
More and more, I'm using polatuzumab up front. I recently gave it to a woman who's 33 years old who presented to her OBGYN with pelvic pain, was found to have a CA-125 of, I think, 5,000. And there was concern that she had a gynecologic malignancy. She underwent an excisional lymph node biopsy. It showed T-cell rich, histiocyte rich, diffuse large B-cell lymphoma, proceeded with polatuzumab, RCHP, and she had a complete remission.
Any tolerability issues, any peripheral neuropathy?
No, she did great.
Any questions about ins and out of using it, toxicity?
Yeah, sometimes if they have peripheral neuropathy that's just grade 1 and mild, I try to push them through it. But what strategies are you taking to potentially mitigate any peripheral neuropathy so I can give them as much polatuzumab as possible? The big question I've had also is more uncommon types of diffuse large B-cell lymphoma. What about using polatuzumab in double hit lymphoma? How about using polatuzumab in triple hit lymphoma? Are we still just using dose-adjusted R-EPOCH for those patients? How about for patients with more obscure types of diffuse large B-cell lymphoma, like the T-cell rich, histiocyte rich diffuse large B-cell lymphomas?
She had a lot of symptoms, including abdominal pain, anorexia, fevers, chills, unintended weight loss. Her liver biopsy showed diffuse large B-cell lymphoma, GCB phenotype with MYC and BCL2 rearrangements on FISH, so double hit. The questions that I have are the role for CNS prophylaxis, because the data continues to evolve and how efficacious that really is and when to actually give it. And I do think it would be interesting to know where polatuzumab CHOP fits into this. I wonder if that's something that we would think about for double hit lymphoma.
These cases typify a plethora of variations of an important and common clinical question, specifically the role of pola-R-CHP, for example, based on disease subset, ABC versus GCB, and specifically in these two cases. We're also interested in your approach to CNS prophylaxis and your experience with side effects and toxicity of the pola-R-CHP regimen, and your thoughts about the potential role of pola-R-mini-CHP, as in the fabulously named Polar Bear trial.
Great. Well, let's jump into some of the questions from these cases. The first is a straightforward but not necessarily simple yes/no question. I had not seen a patient who had abdominal or peritoneal involvement with CA-125. What about you, Laurie? Have you ever seen that?
I've never seen it, but it's not something I would routinely measure. So I can't comment. If we actually tested it on all of our patients, will we see a small percentage? I think this suggests that it's possible.
Yeah. Matt?
Yeah, I have seen it. I think it often is tested before we know the diagnosis is, and I think in this clinical presentation, they were thinking that this was a gynecologic malignancy and why it was, but I have seen it elevated in lymphoma.
And perhaps a second and much more common question, Laurie, as we think about the data from the Polarix trial, how do you think about therapy in frontline diffuse large B-cell lymphoma currently for patients with double-hit lymphoma and for other lymphoma subsets?
Well, as we know, the Polarix trial actually showed an improvement in progression-free survival with the addition of polatuzumab to the R-CHP backbone, and I think has really become a legitimate standard of care. It's hard when we subset that trial out. We know that there were forest plots associated with it. It looked like there might be preferential activity within the ABC subgroup, for example, versus GCB subgroup. That was by gene expression profiling. We don't do that in routine practice. I think it's far more complicated than just a cell of origin division. And we'll see more data emerging on the biological subgroups, I think, at ASH this year. The double hit question, I think, is difficult. That study only included a minority of patients with double hit. There wasn't a suggestion of preferential benefit, but I think it really was too small a subgroup to even comment on.
Great. And if there's time, we'll return to the question about CNS prophylaxis in the audience Q&A. Let's jump into our second set of cases from two other community providers who have frontline cases for patients with diffuse large B-cell lymphoma.
The next two cases of clinically localized disease reflect common clinical questions with these patients.
This gentleman is a 52-year-old male. He initially had an upper viral infection that didn't go away and persisted in sort of a right-sided throat soreness. So he eventually was seen by an ENT, and he was found to have a tonsillar mass and underwent a biopsy that confirmed diffuse large B-cell lymphoma of a germinal center subtype. Everything was sort of right-sided on his neck. I elected to give him an R-CHOP regimen for 3 cycles, and at which time we repeated a PET CT that showed a complete response to therapy. There is some newer data in regards to proceeding with radiation therapy for these limited stage disease folks versus further chemotherapy like R-CHOP ×4. And I was wondering what people were doing in clinical practice.
Very interesting case for you, Neil. This is a 70-year-old man who kept going to his dentist with teeth that became wobbly, as he put it. They were loose, and one of them he actually pulled out himself. He saw his dentist and he pulled a tooth, suspected that something was not right here, and he sent that tooth to a pathologist for evaluation. And the pathologist called him within 48 hours. She confirmed a diffuse large B-cell lymphoma at the root of the tooth. So he was referred to me, and I sent him for a PET scan, which shows this really destructive process in the jaw there. You can see that the bone has been destroyed to some degree and very hypermetabolic in that area there. And strangely, that was the only site of disease. treated him with R-CHOP times 2, and he immediately felt better. His teeth felt better. This pain that he'd had in his jaw went away. And on the PET scan, he had a CR. So I completed the treatment with R-CHOP times 6. Again, discussed radiation, but because of the involvement of his jaw and the fact that his jaw had already partially necrosed, we decided against radiation, and he's now more than a year out without recurrence. How often do you see involvement of the jaw or the gums? This is a first for me in my 23 years of practice. In a patient like this with unusual disease that's near his brain, do you use CNS prophylaxis? And finally, what would you consider to be the role for radiation therapy in a patient like this?
We would love to hear your thoughts on the questions about these cases and experiences, if any, with oral dental presentations, as with Dr. Rupart's case. But we're also very interested in your thoughts on the potential future role of polar R-chip in limited stage disease.
Yeah, for me, these are two other provocative cases. The most intriguing to me is who was that dentist? Because that's exactly who I want for my dentist if he's making a diagnosis of diffuse large B-cell lymphoma. Really outstanding work there. But this sounds to me like a case of a bone-only diffuse large B-cell lymphoma that occurs in other locations. I have seen it in the mandible previously. Maybe starting with Laurie, how do you think about these types of bone-only diffuse large B-cell lymphoma, and how would you manage those currently?
Yeah, I would agree. I've seen a couple of cases present just like this in my own clinic, and sometimes it's a protracted diagnosis because, people think it's a primary dental issue, but I don't think it's any different than other cases that we see of bony disease at other sites. I don't think that there's any difference in my management plan for those patients. So often they can be isolated and maybe amenable to a limited stage approach, but I don't think they necessarily portend a poorer prognosis. DLBCL, and I'd say that regardless of the site of presentation, I tend to manage them as all other patients with DLBCL. I don't think there's a specific role for radiation beyond what I do in my other patients with limited stage disease, and that is that we have moved largely to a PET-based approach where we only use the radiation in patients who seem to be having a poor response after 3 cycles with persistent PET activity.
Matt, anything different that you would do in this setting?
Yeah, I think that it does come down to what the location that would be radiated is and what's morbidity that would come with radiation. In this scenario with the tonsillar involvement, that would be a very morbid, I would think, a location to radiate. But also as kind of you get through several cycles of the chemotherapy, toxicities may arise that may make radiation more favorable because you don't necessarily think that they're going to get the full course of their treatment. With regards to the mandibular, I agree with Laurie here that you've seen it all over the body. I don't usually say one location in the bone is different than the other than pathologic fractures, so on and so forth. That this person's likely going to have jaw issues for the rest of their life because of the integrity of the bone has been compromised.
Yeah, I completely agree with both of those approaches. And Matt, what about the question of CNS prophylaxis in this era with limited data in that setting and perhaps a setting where there's unlikely to be more new data? How would you manage?
Yeah, CNS lymphoma is like that fly in your car that you just kind of continue to swat at and my practice is always changing around this. And what I thought 6 months ago, 12 months ago is completely different. I've went to typically a one and done at cycle 2. If I want to do check their CNS, if they're asymptomatic, I check. I do flow. If they're negative, I don't give any more prophylaxis. I think that the site that I pay most attention to is renal adrenal in those locations. Then I will have a little bit more angst about doing some sort of prophylaxis. What that prophylaxis is, jury's still out.
What about you, Laurie? What do you do now for CNS prophylaxis?
I agree. There's just so little data to support that it actually serves a purpose that we've really withdrawn the use of CNS prophylaxis for most of our patients. I don't think IT therapy, intrathecal therapy, has a role anymore. So if I were to consider CNS prophylaxis, it would have to be systemic methotrexate. And I would agree with Matt. The main group of patients I worry about are those with adrenal-renal involvement because their risk has been shown to be quite high. And I don't think that from the data that's out there, we can parcel out whether or not they benefit. But I've pretty much omitted it from all other patients.
Yeah. I think if you want a dealer's choice of other options to consider, I agree with both of you that there needs to be some risk-adapted approach for being able to choose who gets CNS prophylaxis. We now have observational data that say that intrathecal methotrexate alone is probably inadequate prophylaxis. Other data that suggests that systemic methotrexate is equally inadequate. And so in the rare settings where I consider some sort of combination intrathecal prophylaxis, but also bearing in mind that the majority of the disease tends to be parenchymal when you see relapses. And so you need something that has parenchymal penetration ideally. So let's next jump into my talk about the upfront management of patients with diffuse large B-cell lymphoma. And I think, really the setting that we face in diffuse large B-cell lymphoma is well shown here by a series of negative trials that have been randomized controlled trials looking at ways of trying to improve upon R-CHOP. First with the changing of the anti-CD20 antibody with the G-CHOP regimen, intensifying therapy with dose-adjusted EPOCH as shown there, adding in or substituting in additional agents with bortezomib in a series of 3 trials, ibrutinib, or in 2 trials with lenalidomide, none of which in randomized controlled phase 3 trials showed a distinct advantage for any of those regimens over standard R-CHOP. I think the other thing that's important to note, both in this trial and in the Polarix trial that I'll talk about next, is that throughout this time period, the R-CHOP arms of the standard of care have fared quite a bit better than what we've seen historically, whereas in population-based studies, we see that R-CHOP produces about 2-year progression-free survival of about 60%, and in many of these trials and others, that R-CHOP is producing 2-year progression-free survival of nearly 70%. And so the Polarix trial was an additional attempt to be able to improve upon standard R-CHOP. This was one of the largest frontline trials of R-CHOP ever performed, and you can see the publication that happened in the New England Journal of Medicine at the tail end of last year, looking at the substitution of polatuzumab vedotin, a CD79B antibody drug conjugate with MMAE as that drug conjugate. Substituted in for vincristine, where a vincristine placebo was given in that arm of the trial, and a polatuzumab vedotin placebo was given in that arm of the trial. 2 additional cycles of rituximab were given following the 6 cycles of therapy, owing to groups in Europe that typically give 8 total cycles of therapy as opposed to the 6 total cycles that we commonly give in North America. And so this shows the primary results of the trial, showing that it met its primary endpoint that was focused on progression-free survival, showing a hazard ratio of 0.73 that was statistically significant, indicating a 27% reduction in the relative risk of death, progression, or relapse for patients who receive that. And here illustrates the point that I made earlier, is that if you look at the 24-month progression-free survival, that was 70% for the group that received R-CHOP versus 76.7% for the group that received Pola-R-CHP. I think the other things to note, as has been shown previously and in the New England Journal of Medicine publication, is that the safety profiles of these 2 agents were quite similar, with similar incidents of peripheral neuropathy, and I think that was well described in the case that you heard about. As well as slight increases in the rates of neutropenia in the group that received Pola-R-CHP, and GCSF simulation is needed for those patients as a part of that, but no significant increases in the rates of infection for that arm. I think one of the things that has come out recently is the data that were originally published on the forest plot that described the results in particular subsets. I will caution that although these were planned subset analyses, that these were not subsets that were powered to be able to look at differences for those. It's really to show the overall trend in terms of the groups of patients that benefit. And so as we're having individual patient discussions, really any patient that was eligible for this trial are the patient populations that we think are likely to benefit from Pola-R-CHP or over R-CHOP. There was a recent New England Journal of Medicine commentary that was presented by Dr. Elizadeh discussing that in more detail about the ABC subgroup in particular. And as Dr. Sehn mentioned, there will be additional data that get presented at the ASH meeting. that help us to understand better what subsets from a biological standpoint have differences in terms of outcome. Again, but with these being subset analyses, it's really the overall trial results that I think are of more significance for discussing with individual patients. The next set of trials that I'll talk about are the Polar Bear trial. So this was a trial looking at Pola plus our mini chip versus our mini R-CHOP. And this trial really is one that's been looked at older and frail patients that now show data that with similar toxicity profile across those two arms that was presented at EHA this year. These get back to the data on polatuzumab subsets that I mentioned from the ASH ELISA Day that we just presented in the New England Journal of Medicine as a commentary, and describes the ABC subset as one of those subsets. But I think it's important to look at future data that will come to help to address this question as well. So as we think about the evolving molecular classification of diffuse large B-cell lymphoma, there now are newer technologies that help us to understand that better, first with using immunohistochemistry and then gene expression profiling, and now multi-omic approaches that use next-generation sequencing. And those are now being integrated into our understanding of diffuse large B-cell lymphoma. One such classification is shown here. This is the group from the NCI that put forth the LymphGen classification that now subsets diffuse large B-cell lymphoma using whole exome sequencing and copy number into groups, the MCD group, the N1 group, and A53 group, where the majority of those are subgroups of the activated B-cell-like or ABC subtype, the BN2 group, the ST2 group, as well as two subsets of the subsets of the EZB group, those that are MYC positive and those that are MYC negative. I think one of the things that's important to note about this is if you add up the prevalence of all of those subsets, it does not add up to 100. So there are approximately 40% of patients with diffuse large B-cell lymphoma that cannot be classified by these subsets. And there are other ways that we need to think about classification. One of those that has moved forward is in a classification not of the diffuse large B-cell lymphoma itself, but of the lymphoma microenvironment, or the LME, using gene expression profiling that can subset diffuse large B-cell lymphoma into a germinal center-like, a mesenchymal, inflammatory, and a depleted-like lymphoma microenvironment. And I think the important thing to note is when you take those two subsets of diffuse large B-cell lymphoma by gene expression profile, the activated B-cell-like, which we know performs worse, and the group that's a germinal center-like, that even within those two subsets, that the lymphoma microenvironment can further subset that. So you can see the group that's shown as depleted here in the red, or DP, actually had worse outcomes even within the ABC subset and the GCB subset, suggesting that lymphoma microenvironment may be yet another way that we need to target and address differences in outcomes for patients with diffuse large B-cell lymphoma. And so really some of the things that we're looking at moving forward with, so this is a protocol that we have open at MD Anderson that we're running to be able to do this in real time for patients, to be able to look at lymphoma microenvironment and the LymphGen classification, where our first question is to ask, can we get these results back within 7 days for clinicians to be able to use this to be able to make decisions? And there'll be data that get presented this year at the ASH meeting to describe kind of how successful we've been towards that endpoint. I think the places where this will likely move forward and in trials like this, so this is work from my colleague Jason Weston, that is a provocative trial that uses rituximab, lenalidomide, and ibrutinib as the first-line therapy. This was published in JCO at the end of last year and showed that even with a chemotherapy-free regimen in the first 2 cycles of therapy, that only 1 of the 58 patients progressed, which suggests that we can perhaps move towards regimens where there are some patients that may not need chemotherapy as part of their regimen. And Jason has since moved that forward in a trial with a regimen that he calls Ultra, that uses the combination of lenalidomide, rituximab, acalabrutinib, and tafasitamab in the frontline therapy, giving 4 cycles of a chemotherapy-free regimen. And we now have the first cohort of 30 patients who have been treated with that regimen. And these data also will be presented this year at the ASH meeting. I think the other data that are important to this come also from the Polarix trial, where we've used cell-free DNA as a component, or circulating tumor DNA as a prognostic marker. And this shows that when you look at those patients who are circulating tumor DNA positive, shown in the orange and red curves for R-CHOP and for Pola-R-CHP, that those are patients that have work progression-free survival and overall survival, suggesting this is yet another way that we can utilize our data on molecular subsets to be able able to affect outcomes in the future. So with that, I will move on to our next session with kind of the major take-home points, meaning that polar R-CHP provides a novel first-line therapy, and we really need to think about how molecularly stratified approaches for targeting therapy in diffuse large B-cell and using circulating tumor DNA move forward in the future. So let's move on to Module 2, and then we'll have our next set of cases, and then have Dr. Lunning present. So these are our next two community practitioners who will present another set of two cases.
Things have never been moving as fast as they are right now in diffuse large B-cell lymphoma, with multiple new agents and regimens, particularly the evolution of CAR T therapy and bispecifics. The clinical variables in this setting are also numerous and challenging to integrate, but here we go with some rapid-fire cases for you to make teaching rounds on.
He was 68 years old, very nice guy. He had advanced diffuse large B-cell lymphoma. I treated him with R-CHOP at the time. He had a good response, but towards the tail end of his treatment, he relapsed. So this was bad disease. And so, we had a clinical trial at a higher institution in town that was looking at CAR T-cell therapy as a second-line option. But due to his coronary artery disease and unaddressed obstructive ischemic cardiac disease, he was not considered a candidate. So now, the question was what to treat him with.
This is a 70-year-old gentleman with multiple comorbidities. When I first met him, he was in florid heart failure, kidney failure. He got through treatment. It wasn't pretty, and he was co-managed with cardio-oncology and nephro-oncology. And after completion of his chemotherapy, he was in a PET-CR. And then, like medicine does to you, throws you a curveball. We'd been doing great, saw him, life was good. He went to his dermatologist because he noted a bump behind his calf that he hadn't thought anything about. And it was biopsied and revealed a diffuse large B-cell lymphoma leg type. And this is just presented to me a few days ago. So the questions would be, what is the optimal treatment and our goals of treatment, curative or palliative? Where do the newer medications such as polatuzumab with bendamustine and rituximab? Can we use Lonca here, tafsitamab with lenalidomide? And now that we have this new class of drugs, bispecifics, where do they fall into the treatment algorithm? Are these medications that should be given in community? Are they best given in academic centers? And what is the likelihood of cytokine release syndrome and the neurologic toxicities?
Both of these cases focus on management of patients with coexisting cardiovascular disease, and we'd like to hear your comments on the cardiovascular contraindications to the use of CAR T therapy and bispecifics.
Great. Well, we will jump into Neil's question in a moment, but there is a burning question from the audience that's come up multiple times about the frontline therapy in terms of the use of the polar R-CHP regimen in double-hit diffuse large B-cell lymphoma. So maybe first go to Matt and then to Laurie for that question quickly, and then we'll come back to the relapse setting.
Yeah, I have not transitioned. I still give dose-adjusted EPOCH-R, and I double-hit patients, especially these patients who have high IPI scores. They usually come in hot, and dose-adjusted EPOCH-R historically cools them down.
Yeah, I agree. I don't think we learned anything about that subgroup from Polaric, so this really is not data we can rely on. I do believe that there's a role for more intensive therapy for those patients, so we continue to use dose-adjusted EPOCH-R for patients who are appropriate, because it is a step up in toxicity from R-CHOP for sure.
I would completely agree with that approach, and I think those are the kinds of patients that we need to enroll on clinical trials prospectively to learn more about the best way to treat them. So now let's get back to the relapse setting, and I'll maybe try and summarize the patient cases. So for patients who have comorbid diseases where you're not thinking about a palliative approach as opposed to a curative approach, how do you think about sequencing therapies? First Laurie and then Matt.
Mm-hmm. So I think both of these cases are really challenging. It sounds like they have bad disease with either primary refractory behavior or early relapse. And this is a scenario where we would probably consider CAR T-cell therapy as a next step based on the data to suggest that it has utility in the second line versus stem cell transplant. Clearly, we're seeing patients here who are not transplant candidates. And I think it begs the question, are either of them CAR T-cell candidates? Probably not from what I'm hearing. So if we move beyond CAR T-cell therapy or transplant in the second-line setting, I think we really have to ask, what are the goals of therapy? Do we have any curative options? We've got a whole list of new options to use, but I think we'd be hard-pressed to say any of them are curative. Bispecifics, the verdict is still out. We know some patients achieve very durable benefit. My preference would be they're not approved in the second line setting, so you might have to do something next. But I think a bispecific would be very attractive as probably the agent with the most likelihood of getting durable control and probably the least toxicities in this type of patient.
Matt?
Well, I think in the first case, you have to address the unaddressed, which is the cardiovascular disease. And I don't know that we have enough information about the cardiovascular disease to say that this patient may not be a CAR T-cell candidate. We do have the pilot data. We know that patients with lower EFs can get through cellular therapy. So while it may not be my next option, I would be addressing and trying to control the disease without hurting the patient. And while kind of trying to figure out more so, if they do become or could become a CAR T-cell candidate, understanding that if they're not, then bispecifics would come in the third line in this setting. What would I give in the second line to kind of limp along? I think if you're talking chemoimmunotherapy, then I would be a GEMOX or an R-GEMOX, candidate. But I'm a little concerned because patients chemo-refractory up front. And so then, Tafa-Len comes in, but you have to look at the creatinine clearance in those individuals. I don't think if you're going to use that, you have to know, because dose reductions of lenalidomide would be necessary if you're going to go down that path. For the second case, we don't know if this is a localized relapse of large cell lymphoma and a palliative intent disease, or if this is a florid systemic relapse. In some cases, if it's a solitary relapse in a palliative intent case, I may radiate that individual and live to fight another day, understanding and having that eye-to-eye discussion that high odds your disease is going to come back, but it may come back 3, 6, 9, 12 months from now. So I think that both of these are, as Dr. Sehn alluded to, very difficult cases, but very realistic cases, things that we see in our clinic every day.
So Matt, you touched upon the toxicities and the renal toxicity in particular of the tafasitamab lenalidomide combination. What about toxicities of loncastuximab tesirine? What do you look out for there, and what things do you worry about, and how do you manage those?
Yeah, I will speak to this in my presentation, but I often call it Lonca-T-Dex. Okay, because there are certain things about Lonca-T that you can help risk mitigate the toxicity profile, which was learned over time in the development and the growing up of this drug, namely pleural effusions, cardiac effusions, as well as peripheral edema. My lens when I'm using Lonca-T is the pretibial region. If they're starting to get edema there, then I'm paying very close attention to the bases, rails, any dyspnea on exertion, so on and so forth, because I will ask them, are they taking their dex the day before, the day of, and the day after? But I'm also looking to early implementation of diuretics, typically spironolactone, in these situations. What I know about Lonca-T is it works. It can work fast, but you may not also get patients through their full course of therapy for a year. And if they're in a CR, that's probably okay based upon some of the swimmer's plots that I've seen with that data as it continues to mature.
Great. No, thanks, Matt. And Laurie, I would love to ask you more about it. We heard about how you manage patients who are not eligible for CAR T or for auto transplant. I'd love to hear about those patients that you consider more eligible. But we'll see in Matt's presentation the algorithm that you wrote. And so I'll perhaps turn it over to Matt, the podium to Matt, to give his presentation about how we deal with strategies for relapsed and refractory DLBCL.
So for those of you who have heard me speak before, I often do my talks late, and I usually come with some sort of inspiration. So this is not me, a picture of me, but this is a picture of Garry Kasparov playing Deep Blue in a game of chess. Okay, but I have had my hands like this, trying to think about what I'm going to do next in a relapsed refractory large cell lymphoma patient here. So here's the theme. The theme is chess. So Scholar 1 alluded to that we needed a new strategy in diffuse large B-cell lymphoma in the relapse refractory setting. Patients were no longer having long-term survivals. We were looking at median overall survivals of about 6 months. And those patients who were primary refractory, those patients who were refractory to second-line therapy after a relapse, or those who had relapsed after an auto transplant. You can see here the prognosis is dismal in that population. And we need to drive home to not only lymphoma doctors, but to those in the community that this is a poor prognosis group, and we need to identify that and respect that. So with that, where were we in 2010 in regards to battling against relapsed refractory large cell lymphoma on the same playing table? I think we were playing checkers at this time, and now as we move in to the future, we're now playing chess. I'm going to show that because this is what we were doing in 2010, right? We were switching out monoclonal antibodies, but still giving a baseline RGDP, RDHAP, or an RICE, depending upon where you were trained or what geographical location you were at, you chose what you were doing. The outcomes were still not good, but we were able to use this as a baseline to really spur on the discussion of what we should be doing as we move forward novel therapeutics. So fast forward to 2017, and for those of you who watched the Queen's Gambit, there are other gambits also to start off in a chess match, the Danish Gambit. And this is where CAR T-cell came into play. It came in the third line, and it came in like a wrecking ball to the lymphoma. You can see here, but part of how we had our issues was trying to figure out in a clinical trial who was a CAR T-cell candidate and who wasn't. But the biggest driver of who couldn't get to transplant was the disease, and CAR T-cell was really agnostic to the disease biology before it. It could put people into CR, and that durability could be maintained. You see here with the 5-year data of Axi-cell, there is still a plateau in this population that would not have otherwise likely done well and had this amount of durability. There are people out there alive who would otherwise not be alive as a result of CAR T-cell therapeutics. So let's move forward and let's play the Queen's Gambit because CAR T-cell works so well in third line. What is it going to do in second line? We're still learning the fringes of CAR T-cell, right? We have pilot data where we're expanding the patient population. We have the Alcante data, very similar to that. But where are we going in second line, and why did it go into second line? Well, we saw the ZUMA-7 trial. That was a positive trial. You can see the highly significant hazard ratio of Axi-cell versus standard of care in a randomized trial. You can see the 24-month event-free survival outcomes here in favor of Axi-cell. But really what hit the press this summer was that there became an overall survival advantage. So what does this mean in my clinic? It means that I should be getting phone calls immediately when a patient is either primary refractory or relapses within 1 year of the end of their therapy, because we need to be having that CAR T-cell conversation because every day matters in CAR T, and CAR T-cell doesn't happen tomorrow. It happens apheresis in a couple of weeks and infusion often in 6 to 8 weeks later. So this overall survival advantage in ZUMA-7, I think, is a monumental shift in the second-line high-risk large cell lymphoma population. That was followed also in the kind of competitive landscape of clinical trials with the Transform trial, which is also a randomized trial. We could go on and on about the differences between ZUMA-7 and Transform trials in regards to population and the trial, but nevertheless, the primary endpoint of the Transform trial was also positive in regards to an advantage with liso-cel compared to standard of care. There wasn't a statistically significant advantage in overall survival with liso-cel in the Transform group, but you have to understand there is some statistical differences here, a number of patients, and so on, and I would be happy to talk to you out there about some of those outcomes, but because of time, I'm going to move on. So we are resetting the board, and Dr. Weston and Dr. Sehn wrote an excellent article about second-line therapy in large B-cell lymphoma, understanding that 3/4 of the relapses happen within the first year of therapy. And then there's that whole separate group that we're not going to talk about today, which are those who have relapses often later on, where you would still do standard second-line chemotherapy and try to offer them a transplant. But let's look at some of the options in second and third line and beyond in large cell lymphoma outside of CAR T-cell. So I'm going to talk first about polatuzumab vedotin, bendamustine, rituximab. I can remember where I was when Dr. Sehn was standing in front of a poster at ASH, and I was like 10 feet deep trying to figure out why everybody was swarming around her. And it was because of this trial, and because of just the surprising nature of the outcomes. That with bendamustine and rituximab, a well-tolerated regimen that we can use in large B-cell lymphoma, by adding polatuzumab, not only do you double the overall response rate, but you double the complete remission rate. And oh, by the way, there was a progression-free survival advantage by just adding polatuzumab to BR. But I think what got everybody really knocking at the door here was that there was this overall survival advantage by adding Pola to BR. And that really, I think, led to the approval of this regimen. But was it a fluke? So there was an extension cohort that looked fairly similar, not only in regards to the PFS and expanded 106 patients to get Pola BR, but also within the median survival. So yes, it did get approved, and then it did also get some have some finesse to it, where it now has become Pola plus minus Benda plus minus R. So it really gave us this drug as in the second line as a pre-apheresis, post-apheresis bridge CAR T cell, which a lot of us are doing. But now we're running into a situation where polatuzumab is moving into the front line. So now we have to rethink potentially our strategies. What about tafasitamab lenalidomide? So tafasitamab, is our naked CD19 antibody that has been enhanced for increased ADC, ADCP, as well as direct cell death. It does have a partner that it has to play in the sandbox with, and that's lenalidomide. You can see here that the original LMI data, the overall response rate was 60% with a CR rate of about 43%. And the nice thing about this drug, if you can get them in a CR, they have the opportunity to stay in a CR with continued tafasitamab use, whereas lenalidomide drops off after 1 year. Then became some real-world data, looking at 157 patients, mostly from academic centers. But if you look here, the LMIND eligibility was only 11% to meet all of that criteria, where 89% wouldn't have. But we just talked about a little bit about EGFR less than 60. So some of the caveats that come from this real-world experience with Tafalen, and what I would argue is a very heavily pre-treated population, and I can almost, it's not the population that was treated in the LMIND trial. And you can see here the median PFS in that group was 2.1 months, and median OS was 7.3. So really, we're trying to learn where to best position these drugs on the chessboard. Lastly, is to talk about loncastuximab tesirine. So here we go. So Lonca-T, I explained that I call it Lonca-T Dex because when you put it to the patient about the importance of the supportive medications around this, you should label it Lonca-T Dex, Dex the day before, Dex the day of, and then Dex the day after, because I think in this CD19 antibody drug conjugate with a novel pyrrolobenzodiazepine warhead that causes DNA cross-linking, this isn't monomethyl auristatin E. This is a novel payload, and it has novel side effects that I alluded to with regards to edema. Also, you can see some cytopenias, but also those can be mitigated with pre-management, and you also have to watch the LFTs and GGT. Here's the schedule of the Lotus trial. You can see here that starts off with 150 micrograms, and then after 2 doses, it drops by 50%. But even in this patient population, you had a 50% overall response rate with a CR rate of 25%. There can be durability, just like with Tafalen, just like with CAR T-cell, for those patients who go into a CR. I think with longer and longer follow-up, as well as combinatorial data that we're likely to see with Lonca, as well as Tafa, as it moves on up, our partners with people with other drugs in the sandbox, we're going to see how the full potential of all of these drugs. And I think a burning question is what are we doing pre and post CAR T-cell? And I really think we have to reset our semantics here. There is pre-apheresis therapy. There is post-apheresis therapy. We have very little knowledge on what to do in the pre-apheresis period. We also have very little knowledge to do what to do post-CAR T, especially when you're perturbing CD19. And so this is just some very small data set, and I think this data set will continue to grow, of Lonca-T after CAR T can have efficacy, but also you can have CAR T-cell efficacy after Lonca-T. So if I see a patient who's seen tafasitamab or Lonca-T, I am not afraid to offer them CAR T-cell, understanding that CD19 is probably going to be re-expressed over time. And with that, I'm trying to set up Dr. Sehn here nicely that the next piece in play is bispecifics, but I think we're going to go through some cases and discussion further. Thank you.
Great. Well, thanks so much, Matt. It looks like you've done better than Dr. Gary Gasparov in unraveling some of those challenges there. And our next set of cases really do center around the role of bispecific antibodies. And so we'll jump into these cases from the community first.
Continuing on our teaching rounds, here are two more cases of recurrent diffuse large B-cell.
She's a 73-year-old, was very active. She happens to have had non-alcoholic fatty liver disease, chronic thrombocytopenia as a result. I gave her a reduced dose of R-CHOP. She had 6 cycles and achieved a CR. Was doing really well, but sure enough, just a routine CT scan 4 years later showed new mesenteric lymphadenopathy, which was consistent with relapsed diffuse large B-cell lymphoma. She was sent over for CAR T-cell therapy with axi-cell, which she tolerated extremely well. However, unfortunately, within a month, she progressed. I started her on tafasitamab and lenalidomide, and remarkably, she had a complete response just after 4 cycles of treatment. However, subsequently progressed.
I see that she received several other therapies but passed away. Any questions about her case?
Where do we place the bispecific antibodies? Does that come before CAR T? Does that come after CAR T?
How about your 81-year-old frail man, no major comorbidities, recurrence after 6 cycles of R-CHOP, but ECOG performance status at 2, mainly because of the tumor?
He currently has moderate symptoms with cough and shortness of breath. And this is his PET scan showing significant pulmonary involvement as well as some lymph node involvement by his recurrent diffuse large B-cell lymphoma. The question I have for clinical investigators is, how do we differentiate between considering CAR T therapy versus bispecific or another type of therapy, particularly in elderly patients like this who have borderline functional status, quite symptomatic, and may not have the time to get their CAR T therapy? Can we use other agents such as bispecifics? And what is the role of bridging chemotherapy? And if we do use bridging chemotherapy, what agents should we use?
We are very interested in your thoughts and relevant experiences dealing with patients with coexisting hepatic disease, such as cirrhosis and portal hypertension, and with older, frail patients with compromised functional status, both cancer and non-cancer in origin, and how this affects your selection of therapy.
So, Laurie, in a few minutes, we'll hear from you directly about your thoughts about bispecific antibodies and where they fit in. But Matt, for each of these two patient cases and for the algorithm that you just presented, where do you think about placing bispecific antibodies?
Yeah, so I've positioned bispecifics after CAR T-cell right now, but I can imagine a situation where I'm like that circus person riding 2 horses at the same time and standing up on top of them and then deciding to jump on one or the other. I don't think there's data necessarily for that as well, but I can see a pre-apheresis bispecific getting the disease under control while the CAR T-cells are getting lined up. If that patient goes into a CR, by the time I have to try to apherese them, then I stay on that. I stay on the bispecific course. If they're not in a CR and it's time for CAR T, I'll ride the other one.
Great. And Laurie, I know we'll hear more directly from you about that particular topic and about how you think about CAR T versus bispecifics. And so with that thought in mind, maybe we'll turn the podium over to you to talk about the role of CD20, CD3 bispecific antibodies.
Great. I think this is probably the most topical thing in all of the meetings we've been going to lately, because we now have a new class of agent to play with in terms of managing our patients. So we've been hearing about bispecifics. There are numerous ones in development. I'm going to be focusing today on the CD20, CD3 constructs, because those are the ones that have recently made it to market and are now available in the clinic. But when we talk about this as a new class of drug, we're really talking about a form of immunotherapy. So bispecific antibodies are just such. They're antibodies that target two different moieties. In this case, they're targeting CD20 on B-cell lymphomas and simultaneously CD3 on the body's normal T cells in order to induce an immune response. The ones that have been developed, I think it's intriguing to see that there are definitely differences between the agents in terms of the constructs, but more importantly, there are also differences in the way they're being tested in clinical trials. Almost all of them are given initially with step-up dosing in cycle 1 to ameliorate the most common toxicity, which is cytokine release syndrome. Some of them are given weekly, some of them are given every 3 to 4 weeks. We've got IV versions, sub-Q versions, and also within the clinical trials, we've got testing of finite therapy versus indefinite therapy. So these trials, in addition to showing very intriguing results, are opening up a lot of questions in terms of what is the optimal way to use these agents. So we had a series of phase 1 agents. I listed here the most common, or I'd say the agents that are farthest along in development to date. And I think really the phase 1 trials were proof of concept. We had these agents tested as single agents in indolent lymphoma and aggressive lymphoma, and we saw high response rates in very refractory, multiply pretreated patients to really show us that these were going to have clear efficacy. But they've moved forward now in what would be considered a series of phase 2 pivotal studies that have really allowed them to merge onto the market. And I'm going to talk about some of the key data of the agents that are approved or are coming soon. So glofitamab is one of the drugs that is now actively available and approved in numerous jurisdictions. It is slightly different in that it has 2 binding sites for CD20 to 1 binding site for CD3. The pivotal trial in which the data emerged to get it on the market was done in a broad group of aggressive B-cell lymphoma, primarily diffuse large B-cell lymphoma, but included patients with transformed disease and primary mediastinal B-cell lymphoma, and patients had to have at least 2 prior lines of therapy. Again, it's given with step-up dosing in the first cycle. Also unique to this compound, Day 1 requires a dose of obinutuzumab as a way of lowering the normal B cells to try and ameliorate the CRS response. But ultimately, it then gets given every 3 weeks for a maximum of 12 doses, so finite therapy. All of these trials, I'd have to say, were tested in what I would consider very refractory groups of patients. So although they were designed to enroll patients that had at least 2 prior lines of therapy, all of the trials had patients, the majority of which had 3 prior lines of therapy, and most of them were highly refractory to prior lines. And also, as in this trial, about a third of patients had had prior CAR T-cell therapy. When this was published, there was still relatively early data with 12 months of median follow-up, but we saw that the overall response rate was approximately 50% and the CR rate was 39%. And you can see from these curves, although they're somewhat early, those patients that achieved a response actually had fairly durable control. We're recognizing that there are unique toxicities with this. The most common toxicity that we see is cytokine release syndrome, but for the most part, it is low grade and manageable. Looking a little bit more closely at this, we see that it typically occurs with a first dose of glofitamab, and that is on cycle 1, day 8 with this regimen. The majority of patients have only low-grade events, but about a third of patients did receive tocilizumab in this study. But more importantly, after cycle 2, the incidence is negligible. What about epcoritamab? Epcoritamab is also a CD3, CD20 bispecific antibody that is now approved and available. This is actually a subcutaneously administered compound designed to be given a little bit differently, so weekly in the first 3 cycles, and then biweekly, and then inevitably every 4 weeks to be given indefinitely. Their phase 2 trial had a very similar, highly pretreated patient population with at least 2 prior lines of therapy. And again, about 40% of patients had had prior CAR T-cell therapy. Again, I think it's remarkable that we're seeing very similar results with this agent as well. Overall response rate 63%, CR rate of 39%, and again from those PFS curves you can see the durable benefit in patients who achieve particularly a complete response. Most common toxicity, again, seen was CRS, but largely low grade and very manageable. Here, based on the schema of delivery, the most typical time that the CRS occurred was on day 15, and again, was largely low grade with only about 15% of patients requiring tocilizumab. So as these agents start to be used in your own clinic, it'll be very important to recognize the nuances between them, the expectations in terms of when CRS is likely to occur, and of course, we'll all have to develop management strategies to use them in routine practice. I'll very briefly mention a third drug, odronextamab, which is not yet approved, but mainly to say that this is a drug that is given intravenously in 21-day cycles, also given indefinitely in the clinical trials that it's been used in to date. Similar data also emerging with very good response rates and this evidence of durable control in patients who achieve a complete response. Toxicity, somewhat comparable. I think it's intriguing to say that the development of this compound was somewhat sequential, where they had only 2 doses in the step-up dosing. They actually had quite a high rate of higher grade CRS, but they now modified the delivery schedule where they have the 3-dose step-up dosing, and they're seeing toxicity, I'd say, that's comparable with the other agents. So a lot of this data has emerged with relatively short follow-up. At the recent summer meetings of ASCO and EHA, we actually saw longer-term data emerging. So now we've got about median follow-up times of about 20 to 21 months with these agents, and you can see here that the curves are sustained. Are they going to be curative for patients? I think the verdict is still out. We have patients that were treated on some of the earliest trials, phase 1 trials, that still remain in remission now 5 years out. So I think we're optimistic that this may have curative potential for some patients. The one thing I'll mention, because we talked about sequencing these in relation to CAR T-cell therapy, I would also agree that in my clinic, these would fall behind CAR T-cell therapy because of the curative potential and the longer follow-up we have with CAR T-cell therapy. But what I think is intriguing is that all of these trials have shown strong benefit and almost comparable benefit in patients who have relapsed despite CAR T. They can actually get very good responses to bispecific antibodies. I won't say much about mosunetuzumab. It's probably an agent that has less efficacy in aggressive lymphoma than an indolent lymphoma, so it's not being developed as a single agent. But there's some intriguing data of mosunetuzumab with polatuzumab as a combination that's being evaluated. It's now being tested in a phase 3 trial against R-GemOx. I think we're so excited to see the data emerge with bispecifics and actually get our hands on them in the clinic for our own patients. But there are a slew of ongoing trials now looking at bispecifics in combination with other agents. So the data is just the tip of the iceberg in terms of what we're going to see in terms of the potential of these agents as they move forward in combination in various lines of therapy, and that data will all inevitably emerge. Probably the only combination I'll point out right now is that we are all eager to see these drugs move forward in terms of lines of therapy, and they are going to be tested in the frontline setting shortly. We saw some data recently presented at the ability to deliver epcoritamab with the R-CHOP backbone, showing in this combination phase 2 arm that it's deliverable, and the response rates were certainly very high. But now we have a phase 3 trial that's just recently opened that's going to test epcoritamab R-CHOP against R-CHOP. So the trials looking at their use in the upfront setting are certainly underway. And I'll stop right there.
Great. Well, thanks so much, Laurie. In the setting of your talk, you answered the most important question, which was how to sequence these therapies with CAR T-cell. And I think you nicely set forward, the path for trials in the future. With that, I'll thank you all for your attention at this session, and I hope that you enjoy the rest of your day and the rest of the conference here. Thank you.